recently your article was published in Indian Heart Journal. It says that treadmill stress test should not be a part of routine health package. Priyank, when will you do your TMT and why?
So it is mainly depending on the positive predictive risk for the increased risk. If there is a age is more than 50, more than 50.
I'm asking when will you do your TMT and why?
Okay. For my TMT, if there is any symptoms of chest and if I am going to do it routine walk and once a day I am finding some chest or chest discomfort first. Second, after age of, I think for me, I will consider 40. After age of 40, yearly or twice, and after 1 year.
I think I would say persistent chest pain with a normal ECG.
Okay, good.
Yes.
And second question, when will you do your wife's TMT?
After 50s.
Why?
It is not like
Because of postmenopausal till 45 there is estrogen is protecting factor, and after 45 extra
How many ladies in the period time you have seen who have got acute infarcts? So that criteria almost is, it is so called protected, but I don't think it is.
yes.
When genes dominate, everything gets screwed up.
But actually, sir, we can say means their lifestyle is more sedentary than male. So,
ये जमाना पति है ना?
yes.
No, but sir, estrogen is protective.
Estrogen is
Definitely, our
It
body
is
is
protective, but there are plenty of aberrations.
the other factors,
Other
diabetes
factors-
are increasing in early age,
Young diabetic ladies, young hypertensive ladies.
and thrombotic occlusion is also a very common thing.
And sir,
young
at
people.
for thrombotic occlusion, anyhow you are not going to click on treadmill.
Different,
Right, so that's a different ball game totally.
Definitely.
What is the importance of family history?
Family history is definitely a strong family history is definitely predictive for early coronary heart disease. Even in females,
Any ECG change that you will subject for treadmill?
that will have control. So basically, treadmill test is a very useful test as a diagnostic test. Every diagnostic test has limited value. Every diagnostic has some probability. Every diagnostic has some sensitivity, some specificity. But what is the purpose of doing a diagnostic test? We come to a diagnosis after ordering some diagnostic test. So it is called Bayes theorem, which incorporates the pre-test risk of disease, sensitivity and specificity of test to calculate post-test probability of CAD. Positive TMT does not mean he has CAD or he or she has CAD, coronary artery disease. So it depends on pre-test analysis of the patient. How much prevalence of disease in that age group, that multiple risk factors, and sensitivity of the test to detect that coronary artery disease. So clinical information and exercise test results are used to make final estimate about probability of coronary artery disease. Ultimately, we are going to do coronary angiography to diagnose the coronary artery disease. But who should undergo coronary angiography? That is the important point. And diagnostic power of maximal when pre-test probability of CAD is at least intermediate. So I will come to that. This is a chart which shows that if a patient has typical angina means there is physical quality of substernal chest pain increased by rest and increased by exertion, reduced by rest and sublingual nitroglycerin. If patient has typical angina or any two of the characteristics are there, then it is atypical angina, and none of them there fits, then it is non-anginal chest pain. So in age group of 30 to 39, and different categories gender wise, it is men and women. If 30 to 39 year age with age of man has typical angina or atypical angina, then he has intermediate probability of coronary artery disease. If he has non-anginal chest pain or asymptomatic, then there is very low probability of coronary artery disease. In same age group, women have typical angina. If he has typical angina, then it is intermediate category for coronary artery disease. If she has atypical angina, then probability of coronary artery disease is very, very low. If it is asymptomatic, then it is very, very good. And then second age group, in between 40 to 49, if man has a typical angina, then it is a high probability of coronary artery disease. If he has atypical angina, there is intermediate probability. Even if he has a non-anginal chest pain, then also the probability is intermediate. This is derived by studies. In women, if 40 to 49 years of age woman has typical angina, then also it has intermediate probability of coronary artery disease. And if she has non-anginal chest pain or atypical angina, then probability is very low. As age advances, in age 50 to 59 years, man has typical angina or atypical angina, he has high to intermediate probability of coronary artery disease. Same age group, women have intermediate probability of coronary artery disease with typical angina or atypical angina. And as age advances, like 60 to 69 years, they have very high to intermediate probability of coronary artery disease. So this chart explains that if you are suspecting intermediate or high probability of coronary artery disease, then you should order a treadmill test to diagnose coronary artery disease if it doesn't fit into the acute coronary syndrome and patient is having angina, typical or atypical. So at least intermediate probability of symptoms should be there. In asymptomatic angina, patient they go for TMT as a part of routine health checkup. They are generally around 30 to 40 years of male or female. They don't have any symptom and they go for TMT. Then what happens? Generally, TMT is good.
So what is the source of that previous table and which year it was published?
Sir, actually it is derived from many studies. It was a part of Indian Heart Journal, that article, and they published
Is
derived
this
from
fairly
many.
recent one or it is a decade ago this?
No, this is recent.
Recent.
Yes. In asymptomatic population, prevalence of abnormal TMT is 5 to 12%, but that is also age dependent and risk factor dependent. Not every asymptomatic people. Risk of developing a cardiac event is approximately 9 times when test is abnormal. And future risk of cardiac event is greatest if the test is strongly positive or has multiple risk factors. So general prognosis of coronary artery disease is better than symptomatic patient if effort tolerance of patient is good. So when you go for TMT, patient is asymptomatic, TMT changes are there. But if he completes 7, 8 max, then it is a good prognosis of coronary. Even if there is coronary disease, the prognosis is good. Many studies this I have highlighted. People who tested positive on a TMT but subsequently were found to have normal coronary arteries on invasive coronary angiography, despite having no increase in coronary events or mortality, had increased risk of hospitalization for chest pain. They repeatedly admit or come to OPD for complaint of chest pain after doing coronary angiography also. This I think we have also faced this much, particularly for women. They were complaining of every time they were having chest pain. In symptomatic patient, exercise ECG should be routinely performed in patient with chronic coronary artery disease before coronary angiography. Even if we are suspecting there is coronary artery disease, even if we found coronary artery disease, then also TMT is a useful test because patients with good effort tolerance, better than 10 meds, have excellent prognosis regardless of anatomical extent of coronary artery disease. No matter how much coronary artery disease is there, if he completes 10 meds, then it is a very good prognostic factor. Provides an estimate of functional significance of coronary angiography in a documented coronary artery stenosis. Before fractional flow reserve, before FFR, we used to do, first we do coronary angiography, we find a borderline lesion, then we advise patient to go for treadmill. If treadmill is positive, then the functional significance of that intermediate block is proven. So nowadays FFR is a good test, but before people used to do this TMT after doing coronary angiography also. There are some protocols regarding treadmill. I'm not going into detail of that. Generally, we use the Bruce protocol, in which 3 minutes period to achieve a steady state before workload is increased. Modified Bruce protocol is for senior people, older individuals. In this modified Bruce protocol, the 3-minute warm-up stages are there at 1.7 miles per hour at 0% rate and 1.7 miles per hour at 5% rate. So there is a lower workload compared to those protocol for older individuals. Now coming to diagnosis of positive test. So we use modified lead modification, modified leads for the TMT. Arm leads are put on the torsos. So it results in normal deviation of the cardiogram, which is right axis shift, increased voltage in inferior leads, loss of inferior Q waves, and new Q waves in lead AVL. These are the normal variation from the ECG in normal, in TMT chest leads. So coming to ST segment displacement, generally J point junctional depressions are normal finding in exercise. Just after the QRS there is J point, which can be depressed at the increased heart rate. In myocardial ischemia, ST segments becomes horizontal, and with progressive exercise, depth of ST segments may increase. So depends on that is also a prognostic factor how much ST depressions are there. If ST depressions are more, then probability of coronary artery disease is more. And also the recovery part is important. Sometimes we get changes in only recovery period. Throughout the test is normal, but after in recovery period there is ST depression. That is also a good prognostic factor. Actually, what happens is after exercise, when patients are at rest, after exercise in recovery period, LV volume increases due to this exercise, and that increased LV volume will give you changes in recovery period. So coming to measurement of ST depressions, generally PQ junction is chosen as an isoelectric point, and abnormal ST depression is greater than 1 millimeter or 0.1 millivolt from PQ junction with a flat or downsloping ST segment slope 80 milliseconds. There is two small boxes after the J point. We should measure J point after that 80 milliseconds, two small boxes, and then ST depression should be measured. And in 3 consecutive beats with a stable baseline. So when ST segment F heart rate is more than 130, then 80 milliseconds is the criteria, which is with less to 60 milliseconds. So 1.5 small boxes, after that you should measure it. And when ST depression at rest is additional 0.1 millimeter or more during exercise is considered abnormal. So when you are talking about when baseline ECG is abnormal, then how much ST depression in baseline ECG? After exercise, if depress is more than 1 millimeter, then it is a positive treadmill test. So these are the typical ST depression on ECG. The one number first is PQ segment, second number is J point, and third number is ST segment. These are the upsloping ST segment. Rapid upsloping ST segment depressed less than 1.5 millimeter after J point is normal. And slow upsloping in patient with high coronary artery disease prevalence, slow upsloping ST depression more than 1.5 millimeter after 80 milliseconds of the ST segment is considered abnormal. So slow uprising ST depressions are considered as abnormal. This typical horizontal ST segment depression, definitely probability of coronary artery disease is there. If patient has ST segment elevation, then definitely TMT is positive, and it detects the territory of the ischemia also. Means in ST elevation is generally considered as territorial thing. If in anterior limb, then anterior MI, inferior is inferior MI. These are the same ECGs. T wave changes. Transient conversion of a negative T wave at rest to positive T wave in exercise, it is a pseudo normalization, and it is a non-specific finding, does not enhance the diagnostic or prognostic content of the test. So T wave should not be looked. In patients with LVBB, exercise-induced ST segment depression is seen in LVBB and can't be used as a diagnostic indicator. So if patient is complete left bundle, there is no use of actual treatment test. New development of LVBB, which is incidence is around 0.4%, and it is considered as ischemic. Relative risk of death or other major cardiac events with new exercise-induced LVBB is increased threefold.
There is an add-on to this that if your hemodynamic changes during symptoms, then the test has to be looked into.
But sir, if patient has pre-existing LVVT, then most of other common probability is cardiomyopathy. So in that also we can get the TMD changes
Because
because
cardiomyopathy, you don't get chest pain as much.
no, chest pain will not be there.
If the patient
Differential
has significant symptoms or
Symptoms are-
significant hemodynamics, sudden drop of pressure,
yeah, definitely.
then we have to look into it.
Definitely. In patient with right bundle branch block, indicators of coronary in RBBP are new onset ST depression in V5, V6 and inferior leads, reduced exercise capacity and inability to adequately increase systolic blood pressure. Exercise induced ST depression in lead V1 to V4 are common with RBBP and it is non-diagnostic. So after this ECG variables, we have other variables in TMT. First is blood pressure. So normal exercise response is increase in systolic blood pressure progressively with increasing workloads. Generally it ranges from 160 to 200 systolic blood pressure. Older people have higher blood pressure. What is abnormal? When systolic blood pressure fails to increase more than 120 millimeter of Hg or sustained decrease greater than 10 millimeter of Hg, then it is a very good indicator for coronary artery disease. And falling systolic BP below the resting value or generally diastolic BP doesn't change significantly. So conditions other than myocardial ischemia which are associated with abnormal blood pressure response are cardiomyopathy, cardiac arrhythmia, LVOT obstruction and hypovolemia. And exaggerated BP increase with exercise is increased risk of future hypertension. Another thing is maximal work capacity, which is a very important prognostic measurement of exercise stage. When there is limited exercise capacity, if patient does not complete 5 max or so, then it is increased risk of fatal or non-fatal cardiovascular events. In one series, adjusted risk of death reduced by 13% for each 1 minute increase in exercise capacity. So this is a cumulative chart which shows cumulative survival of the patients. Patients who completed greater than 10 max have a higher longevity at 20 years. As max decreases, if it is less than 5 max, then cumulative survival is very low. Another thing is heart rate response. Generally, sinus rate increases progressively with exercise. Sometimes in TMT we do find fibrillations, patient is hypovolemic or anemic, then abnormal heart rate response is possible. What is chronotropic incompetence? Decreased heart rate sensitivity to the normal increase in sympathetic tone during exercise. So inability to increase the heart rate to at least 85% of the age predicted maximum value. So if it does not achieve that, then it is a chronotropic incompetence and it is also associated with adverse prognosis. Another thing is heart rate recovery. Abnormal heart rate recovery refers to relatively slow deceleration of the heart rate following exercise cessation, which is 12 beats per minute or less, then it is abnormal. Chest discomfort, this is the most important thing. Development of typical angina during exercise is a useful diagnostic finding. Chest discomfort usually occurs after the onset of ST segment abnormality. And exercise-induced angina and normal ECG requires assessments during myocardial infarction. Another thing is rate pressure product, but it is not widely used. Heart rate into systolic BP, whichever values come, and there is according to value there is a chart, but it is not used. One interesting thing is Brody effect. So as exercise progresses, R wave amplitude increases normally till around heart rate of 130. And after that the R wave amplitude decreases. It indicates normal LV function or minimal LV dysfunction and it is associated with normal coronary angiography. Increase R wave amplitude in post-exercise period, which indicate ischemia or LV dysfunction. So which I was talking about. It is maybe related to increase in LV and diastolic volume after exercise. So at the end of the exercise, if LV and diastolic volume increases, it will give you increased amplitude of R wave in lateral leads. 25 to 71%. It is highly variable. But in multi-vessel disease, the sensitivity is 81%, specificity is 66%. And if patient has left main disease or triple vessel disease, then sensitivity is 86% and specificity is 53%. There are the other causes of ST segment depression like anemia, cardiomyopathy, digitalis, hyperventilation, hypokalemia, conduction defects. These are all other causes. So exercise parameters which are associated with multi-vessel coronary artery disease when we suspect it. So duration of symptom limiting exercise is less than 5 minutes. If patient cannot complete 5 minutes, then you should suspect either multi-vessel coronary artery disease or left main disease. Abnormal blood pressure response, angina pectoris at low exercise workloads, ST depression greater than 2 mm, which is downsloping, starting at less than 5 minutes, involving greater than 5 minutes and greater than 5 minutes into recovery. This indicates multi-vessel coronary artery disease. And exercise-induced ST elevation except lead AVI. Another very informative thing is Duke treadmill score, which provides survival estimates based on the result from exercise stage, provide accurate prognostic and diagnostic information, less effective in patients with age of greater than 75. What is Duke treadmill score? It is exercise time minus 5 into ST deviation minus 4 into treadmill angina index. Angina index in treadmill is measured as 0 if there is no angina during treadmill, 1 if typical angina occurs during exercise, and 2 if angina was not the reason that patient stopped exercise. So we multiply this factor, how much millimeter ST deviation is there. If we found that patient has, let's say patient has exercised for 8 minutes, minus 5 into if patient has ST depression of 2 mm, then 5 into 10, minus 4, say patient has angina, so score is 1, so it is minus 4. So 10, 4, 14 and exercise time is 8, so score is minus 6. So if score is less than minus 11, then it is a very high risk, TBD or LMC involvement is there. If patient has score between minus 10 to plus 4, then there is moderate risk of coronary artery disease. And if patient has good score, greater than 5, then patient has very low risk of coronary artery disease. So this is a very useful score. Generally, clinically, we less than 5 minutes is a poor prognosis, and peak of cost of basic activity of daily living, he can do only that much. Generally, athletes can do up to 18 or 20 minutes. In women, diagnostic accuracy is less in women due to lower prevalence of coronary artery disease. False positive results are common during menses, pre-ovulation and post-menopausal women on estrogen therapy. In elderly patient, modified dose protocol is generally used. Frequency of abnormal test is more and risk of cardiac events are also more. Subjects greater than 75 years, Duke treadmill scoring test is less useful. In diabetics, in patients with autonomic dysfunction and sensory neuropathy, the angina threshold is increased and abnormal heart rate and BP responses are more reliable. Coming to some absolute contraindication, there is recent significant change in electrocardiogram, acute myocardial infarction, high risk unstable angina, arrhythmias, symptomatic severe aortic stenosis, uncontrolled heart failure, acute pulmonary embolism, acute myocarditis or acute aortic dissection. These are the absolute contraindications of TMT. And relative contraindications are left main coronary artery stenosis, severe arterial hypertension, tachyarrhythmias or bradyarrhythmias, hypertrophic cardiomyopathy, high degree AV block and ventricular aneurysm.